We're going to give everybody just a moment to get into the webinar, and then we'll get started. Okay, I'm going to go ahead and get us started while everybody is coming into the webinar. Thanks for joining us this afternoon. I'm Chrissy Giuliano, Executive Director of the Big Cities Health Coalition. BCHC is a forum for leaders of America's largest metropolitan health departments to exchange strategies and jointly address issues to promote and protect the health and safety of the nearly 62 million people they serve. Gabby, if you can, yep, there are our member jurisdictions. Again, thanks everybody for joining us today. We're really pleased to be able to continue to have these discussions. We'll just go over a few housekeeping things to start. The session is being recorded. All of your lines are muted except for the speakers. You can use the raise your hand feature or chat Gabrielle Nichols if you're having any technical difficulties. And you can also feel free to put questions into the chat. Toward the end of this session, we will get to everybody's question. So I'm really excited today to have two of our great members, Allison Arwady from Chicago and Gretchen Musicant from Minneapolis. So Allison is the Commissioner of Health for the City of Chicago. Before becoming commissioner, she was the department's chief medical officer, overseeing disease control and environmental health, emergency preparedness, and behavioral health. Prior to that, she worked for the CDC as an epidemic intelligence service officer. I always throw all those words together, so I have to say them really slowly, based at the Illinois Department of Public Health. She earned her bachelor's degree from Harvard, her master's degree in public health from Columbia, and completed medical school and her clinical training at Yale. And as I was putting this together, I realized that makes you triple Ivy. So Gretchen Musicant has been the health commissioner in Minneapolis for about 15 years, having been with the department for about 20 years. Prior to that, she was the vice president of community health for the Minnesota Hospital Association and a government affairs specialist for the Minnesota Nurses Association. Gretchen has a great deal of public policy experience as a state level lobbyist and as a fellow with the Humphrey Institute. She has chaired several statewide and regional efforts and is currently on the board of NACHO, the National Association of County and City Health Officials. In 2014, she received the Gaylord Anderson Award for Leadership in Public Health from the University of Minnesota School of Public Health. She holds a BS in nursing and a master's in public health from University of Minnesota. As we were putting these together, Gabby had written in U of M, and I had to actually put Minnesota in, so I didn't actually say Michigan. So anyway, thank you both for being here. Again, really happy to be able to have this conversation. So before we get to the current situation on the ground in Chicago and Minneapolis, let's talk a little bit about the early days of the outbreak. So Allison, Chicago had one of the first cases in the country. How did that first case prepare you for what was to come sort of later in the winter and the spring?
Yeah, so we did have a very early case, and then we actually had the first case of the human-to-human transmission when our first case had transmission to the spouse. And at that point, we had already activated actually for COVID because O'Hare was one of the receiving airports for travelers coming initially from China. So we had already opened our EOC, but at that point, we were very much in full containment mode. And so this was, we followed hundreds of contacts of these individuals. We were able to sort of have a big celebration when we had not seen further spread. But I think it highlighted, first of all, just that everybody was going to assume that this virus was somewhere that was not them. At that point, that meant China and Chinatown. And I was having to go eat lunch in Chinatown and having to sort of share that this was nothing to do with where this person lived or what the exposures were. But that, I think, predated what we very much saw coming where we look ahead. And I think the other thing is just that it triggered a lot of the preparedness work that we had done even before that. Crimson Contagion had been this big exercise that we'd done the prior summer where we had practiced delivering the PPE from our stockpile and standing up the morgue extensions and doing all of the communications. And so we were already dusting things off a little bit, but at that point, treating it more like Ebola and like something that we would be able to contain at an individual level.
Okay, sorry, I thought I unmuted myself. Gretchen, how did you prepare based on what you were seeing in other regions, and what were your experiences early on?
Thanks, Chrissy. And this was a little bit of an exercise in memory for me because it has been 6 months, and like others, it seems I've lost all sense of time. But our first cases came in the middle of March. And so by that time, it was clear that PPE was an issue, and the supply of PPE was not going to be abundant. And we had a stockpile of N95 masks and surgical masks left over from H1N1, actually. And so we began to look at them and see if they had expired and if we could keep using them. And if so, how could we get them out to hospitals, to nursing homes, to our own, first responders. The other thing that we did to prepare, and this was based more on some other emergencies that we'd had locally. We had a fire in a hotel for homeless people around Christmas. And we've had a tornado through the poorer part of town. And through those experiences, it was clear to me that usually in an emergency, you pay attention to the stuff, to the doing, and not to the people. And you soon realize that, oh yeah, I got to be talking to the people that are impacted. And so what we did this time was to set a community engagement section right within our emergency response team so that they could be working on that from the very beginning and not wait until, we had a V8 moment where we thought, oh yeah, we should have been engaging the community. And that was very helpful.
Great. So both of your cities also during all of this have experienced protests, civil unrest. Gretchen, of course, Minneapolis was home to the unfortunate killing of George Floyd. So let's start with you, Gretchen. Tell us a little bit about how your community continues to deal with the event, and related, what sort of guidance have you had to offer the community given we're also in the middle of a pandemic?
Yeah, well, clearly our community and many others continue to be on edge. We just had some unrest in the downtown area just this last week. It only lasted one day. It was based on an untrue rumor about a police-involved killing. And so clearly there's so much rebuilding of trust we need to do, but that really has precipitated some really significant deep work on the part of organizations across our city, as well as the city itself. We passed a resolution on racism as a public health issue, and we have action steps and are trying to move forward. During the unrest right after the killing of George Floyd, we were able to work with community groups that we had relationships with and who were out and about as part of the protests, and distribute hundreds of thousands of masks And so really our demonstrations, right from the beginning, had people wearing masks. And as it turns out, outside, of course, and a lot of people wearing masks, there wasn't a lot of spread of COVID as a result of that. And it established some new community norms. It's the Pollyanna in me. We also wanted to make sure that we were getting our messages out to community in different ways. And so we use some of our relationships through our violence prevention work to create a TikTok contest for young people to begin to tell their peers about physical distancing and wearing masks and why they cared about their community. We also worked with we have a youth congress whose motto is "No decisions about us without us," and they put some YouTube videos together, again on social distancing. And we've also worked with the women's basketball league to do some additional, hopefully relevant YouTubes to reach the community to take care of themselves while they express their free speech.
And Allison, you in Chicago have also seen a number of protests. How have you all handled it in Chicago?
Yeah, so, you know, it has been a summer, like here and across the US. And where I think about the timing for us here was interesting because that main initial surge of the protests, you know, after George Floyd's death was exactly when the state of Illinois was moving out of shelter in place. Chicago had actually elected to stay in just a little bit longer. So it was right at this moment of people were going to sort of be thinking COVID was over. And I actually tend to agree with Gretchen that in a lot of ways, the protests, in addition to really raising and sort of becoming linked with what we were already talking about very explicitly, these racial differences in terms of how COVID was presenting and talking a lot about the underlying root causes for that. And that's been a conversation of important and real conversation in Chicago for a while. This was this very physical manifestation exactly at the time where people were prone to think COVID was over. And I think that actually we saw something fairly similar here where protesters were doing a fantastic job by and large of wearing masks and really saying, you know, we want to be responsible sort of about this piece of it, even while it is so important to express. And you know, I remember doing some news conferences right around this time, and even the messaging on this, we basically were saying, you know, we cannot recommend large gatherings at this time. Like we're literally still in shelter in place and we weren't ready quite to come out. But we recognize that the reasons why this is happening are very important to people. And if you are going to participate in a protest, first of all, do these things right at the time, but also starting to get really explicit about, you know, if you've been in a gathering like this, if it is possible for you to quarantine for 14 days, please do that. If it is not possible to quarantine for 14 days, at the very least, do not have close interactions with people who are at risk, older, underlying conditions. And in some ways, this sort of messaging of like, as people are starting to emerge, thinking about how these daily activities that are very important to someone, whatever that is, will then kind of play out as risk in their personal life. It sort of served as this moment to talk about that there are things that are even more important than COVID risk to people, and that we understand that, and that those decisions may be different for different people, but we need folks as they're making those decisions to think about how COVID risk can be limited, and especially not sharing that risk with others. And so I think in that way, you know, it was sort of a moment to try to pull these together. I think, you know, it also has just become like inextricably linked here where, you know, even some of the programs that the city has put forward, you know, we had business assistance programs for businesses that had been heavily impacted by COVID and now also heavily impacted by looting. And we also have had not just that one weekend, but some additional issues. And it's really been, it's put this other layer of tension on top of the outbreak. And outbreaks always, in my opinion, exacerbate whatever the underlying kind of stresses in your society are. But I think they're one of the most, they're the thing that I still get the most mail about, like, why are you still, allowing protests, and how have you not stopped this? That and the vaccination are the two things that people just are really, at least here, have very strong opinions about on both sides. But the good news is we really did not see significant spread from these protests, although people still believe that there has been significant spread. We did see cases, certainly, and we were clear to talk about that. And we used also testing to kind of start. We, for example, partnered with one of the organizers of one of the protests to say, if testing, if you're going to do it, should be this long after an exposure, and here's how it can be available, and tried to sort of use that it was happening to get the messages we wanted to get out about COVID, and then say, but it's not just the protests, it's the big one on TV, it's when you're also just getting together in groups with friends and families. So it's like put this additional complicated layer that who thought COVID was going to get blown off the map in terms of public, conversation and discussion, but it absolutely did that here in Chicago.
Yeah, listening to you, I just thought of a couple additional things. We, along with the state health department, did a lot of pop-up free testing afterwards within 14 days of the protests, and I think that was some of the first public testing that there was, and so really got people sort of started along the path of looking for public testing as well as going to their providers. And then, as you said, it really has exacerbated some underlying problems. I mean, people lost jobs with COVID, and more jobs were lost after the looting, and we had food insecurity early on in COVID, and we continue to have food insecurity exacerbated by losing grocery stores and losing pharmacies, but also the financial wherewithal to purchase food and to take care of families. So that continues to be a very strong factor in our community and probably across the country from a financial perspective.
Yeah, and I agree on this thing, particularly where pharmacies and groceries were out of commission there. Major step-ups by community groups around, formula and diapers and food. And really, we have a race equity rapid response team, which I can talk about, but it brought this like other dimension that was kind of unexpected, and we had to stand up very quickly, almost like after a hurricane or something, where you've literally lost these services in many places across your city. How are you going to make sure these basic needs are met? While it's not caused by COVID, but it's like indirectly sort of related. It's been just another piece on top of this.
So Gretchen, let's go back to Minneapolis, and how would you characterize the state of the outbreak now, and what are the challenges you're facing day to day right now?
Well, we are in a state of significant community spread, and we have improved slightly in the last week. Our cases have come down. We continue to see a lot of young people involved in that. We have done some limitation on how bars can operate that the state has not done, but what we felt we needed to do. We're very concerned with colleges and universities, of which there are several opening up, and because young people have been so central to the latest peak that we've had. And oftentimes it's been social gatherings. So that's really hard to regulate and control other than education. We heard today that there has been a COVID party and another COVID party planned, which is just amazing to me. I thought that was like something people would have done months ago, but not now. And we continue to see very significant disparities in the Black community and the Latinx community. Those rates are coming down, but the disparities are prevailing, even as everyone's rates come down. And we've got a lot more community testing going on, and people's acceptance and interest in that seems pretty significant. But the amount of number of cases and the hesitancy of young people to tell you about their contacts has really made contact tracing a less effective tool right now. And until we bring the numbers down, we'll still keep doing it, but it's not, it doesn't bear the fruit that it does when you have fewer cases and people who are willing to tell you who they've been with.
Yeah. And Allison, how about for Chicago? Where are you today, this week?
Yeah, so, you know, this really has felt in a lot of ways like a different response every month or two in terms of what the primary concern is, what the science looks like, what the advances have been. And I think right now, you know, just for some context, we had a really big surge in heading up in March into April, peaked really in early May. Just to give you a sense of where that was, here in the city of Chicago, we were seeing up to as many as 1,500 cases a day and averaging over 1,000 cases a day. We came down very nicely. Really came down right sort of beginning of July-ish, like I was just talking about. We were under 200 cases a day, and that put us out of a high incidence zone, you know, as the CDC defines. We were really doing very well. And then not surprisingly, you know, as you reopen and people start to feel more comfortable, we've really seen just a slow and continued uptick. Once we got back over 200 cases a day, which for us put us into a sort of a higher risk state, we reinstituted a number of restrictions, closed bars, put capacity at 25%, other things like that. And we've sort of remained in this kind of 200 to, you know, under 400. We had set for us 400 cases a day would be the equivalent of 15 cases per, you know, per 100,000, which is where we quarantine you know, for other states. And we're at like 330 something right now. So it's right in this kind of yellow zone of just watching and seeing slow upticks, not hitting our hospitals. Ours is also very much, you know, predominantly 18 to 29-year-olds, but we're also seeing much more like at least in Chicago, we're seeing our cases really get more like socked in a couple of different sort of neighborhood areas. So there's a part in the Northwest Chicago, a part in the Southwest, and then a smaller part in the Southeast, which have really, we do this hotspot and cold spot analysis like every week. How, you know, where are we seeing in a census tract more than you would expect, less than expect? And we've seen expansion of cold spots and real kind of darkening around these hotspot areas. And they are heavily Latinx communities at this point. More than half of our new cases are in people who report Latinx ethnicity, although Chicago is only about a third Latinx. And so, I mean, yesterday, like I was out, you know, the mayor was out, 50 people were out from sort of this, you know, knocking on doors and just giving out information, really like very grassroots. We're working with a lot of folks in these communities. We've pushed a lot of testing there, but we're really, it's this micro level. How do we make sure that, especially in communities that may have, you know, we know what we really hear is there are a lot of essential workers who are not getting unemployment, who are not getting sick pay, some may be undocumented, and they say, I just can't stop working, right? Like I can't even, I don't want to get tested because I don't want to know. More multi-generational homes, more dependency, lower, like all of these, like there are reasons for this that are structural, but it is challenging to sort of crack this. And so we've been working really hard in a lot of directions, a lot of community partners, you know, funding street teams for the youth that are out, and you know, obviously a lot of interesting Spanish messaging. We just had a call yesterday, like for example, there's not much happening on TV right now, so the White Sox, right, have a very strong Spanish language, and they were like, you know, we can get some Spanish language messaging out. Like we're just trying sort of everything we can think of with a real focus on those areas. But what I don't want to do is like make the rest of Chicago feel like I'm safe, I'm done. So we say we still get cases out of every zip code, and I can't have people thinking that this isn't them at the same time that I need to layer additional resources on. So that is, I would say, by far our biggest challenge right now. And then just ongoing messaging. We do have, as I mentioned, the city of Chicago decided back in early July, when we got back over that 200 mark, but we could see a lot around us really getting into some trouble, and that there was a lot of peak down in the South and in the West, and we have a lot of travel. We did decide to put a quarantine in place actually at the city level for people who were traveling to any state that had a level of over that 15 per 100,000. And that actually, of all the things that we've done, closing our lakefront and then putting this quarantine were the two things that like broke through the noise locally in terms of us. I mean, it was a huge burden in terms of the number of calls we're getting and the hits to the website and communicating about it. But I think it really raised awareness of what COVID looks like, not just right where I live, because you want mostly people to know what does it look like right where I live, but also what does it look like in Chicago, but then what does it look like across the US? And particularly businesses who have said to their employers, you don't travel, right? Like this is not the time unless it's essential. It's been a big pain administratively. Every week we update the list and it's always a thing. But I think from an education standpoint, it's been helpful. So those are some of the things that that are taking up a lot of time just at the moment.
So Allison touched on this. Gretchen, let's go back to you and talk a little bit more about sort of racial disparities. There's also a question that's very similar to a question I was going to ask you, sort of about what you all are doing, given you have incredibly diverse communities or populations, and the disparities, and sort of how does that affect your response, the actions you're doing, you know, ranging from public education, as Allison talked about, to literal resources of testing and things like that. So Gretchen, how have you guys handled that in Minneapolis?
Well, as I mentioned at the beginning when you had me go back 6 months and try and remember, we did set up a community advisory group, shared power advisory group is what we called it, and really intentionally had people on there representing many of the different cultural communities, so that we could have a two-way communication, not only hearing from those folks, but also developing more ambassadors. We are thinking of creating something similar as we lean into the notion that we might have vaccinations, and knowing that there is you know, a level of distrust that we have to overcome. We all have to learn a lot about vaccines are going to be. And so we believe that if we can do that with community, do the learning with them, not deliver the information kind of after it's been discovered, that we will have built a different kind of trust relationship, and we'll be able to talk with communities differently about that. So yes, because we have such diversity within our diversity, we have a number of different community-specific and language-specific radio stations, and so we've been appearing on them and running advertisements and content on them. Certainly working and meeting with community leaders. When we do testing, it's in settings that have been chosen by the community. So it might be a mosque or a Catholic church, or a Head Start setting, or just places where people feel a little bit less official and more connected to something that they truly understand and know about and would regularly visit. We did one of our testing events at the same location as a food giveaway. And so the food giveaway one week, and we publicized the testing for the next. And so we kind of went every other week for that. Yeah, and then I mentioned the different vehicles of TikTok. I mean, I don't even know what TikTok is, you know, but but other people do.
Mm-hmm.
And according to the president, maybe we're not supposed to do TikTok anymore. I don't know, or supposed to take that over or something. But trying to use different vehicles to get information out as well.
I like the phrase you used about lean into maybe the notion of a vaccine. I'm going to use that. And I was going to ask you something, Allison, and it went out of my head. I know that a few months ago there was somebody ranked sort of how equitable testing sites had been, and while many BCHC members got some negative press on that, I know Allison, Chicago was sort of pointed out as a city that was doing it right. So can you tell us a little bit about the mobile testing you've been doing in various communities?
Yeah, absolutely. And to even take a quick step back from that, like very, very early on, our first identified case of community spread was in an African-American man here in Chicago. Our first death was in an African-American woman here in Chicago. And this was at a time where there was still a perception that this was an Asian issue. And there was a lot of misinformation still that Black people weren't getting COVID. And the mayor really decided, in conjunction with the health department, very early on, to set up what we called a racial equity rapid response team around COVID. And this was when about 3/4 of both cases and deaths, as I recall, were in African Americans. And it initially started with that focus. And then when we started to see sort of a significant increase in our Latinx community, expanded to that group. And that group has been interesting because, we often will do, it's public health. So we do a lot of community engagement and here's messaging, but this group really from the beginning has been decision makers as much as they've been somebody to consult on. And so, for example, when we were putting together, how are we going to share our data? Like we put together a data dashboard that I think is very good. And it gets updated daily, and we've been very committed to transparency. So literally, I see the new data at the exact same time that it goes available to the public. We put all of it available. People can mess with it. You can look by zip code. You can do race, ethnicity, age, like slice and dice it any way you can. And we put it all in our data portal. So if you want to download it and do some other things, we really, that was a sort of an ask and a decision quite early on. And we have talked a lot about racial and ethnic disparities really throughout this whole thing. So, I know without looking at my data right now that, 47% of our cases have been in the Latinx community as compared to, right now they're a little over half, but over the whole thing, it's about 47%, even though they're about 1/3 of the city. Deaths, on the other hand, about 43% of our deaths have been in African Americans. They're also about 1/3 of the city. Whites are about 1/3 of the city. Asians are much smaller. But the racial equity rapid response team also really helped. They were the ones who said, here is how we want this data to look. Here is how we should describe this. And it was helpful, I think, because we didn't just put percents. We had, like, if you go on there, it says 1 in 5 Chicagoans has been tested for COVID. You can hover over the zip code, 1 in 20 people in this zip code has had COVID. Like, helpful in terms of kind of turning a lot of the stats and the epi language, I think, into something that they felt like was language that was more useful. And we've got a community group a provider group in there, and we've got like all different kind of sub pieces, but they also really help direct a lot of our testing. And so to your point, that's right. I think it is a real success here that we actually have, our case patterns here look like our testing patterns geographically. Chicago is really quite a racially segregated city. And so if you're matching geographically, you're sort of matching also kind of race ethnicity. And we, in this big national analysis, Black Chicagoans actually had better access to testing than white Chicagoans, and Latinx had basically equal. That's very hard to do, very expensive to do. We've spent at least $20 million like making that happen. But every single week, like by the week, we look by zip code. This is not who do I know, where should it go, zip code by zip code. Where is the highest percent positivity? Where has the greatest increase in cases been? These are the metrics that we then say, these are our communities. And then the race equity rapid response team says, okay, these are the sites sort of within these communities that we're gonna send testing. And we've stood up some more permanent type, not permanent, but regular testing sites in the communities that are the hardest hit. But then we move really every single week. And the health department provides the data, and then the actual sort of deployment is really made by that group. And I think it's been an interesting and good relationship there. But it's you know, we're not done. And I think this sort of what comes next. I know we're a little short on time, but I do want to mention the chronic disease piece maybe, because the health department and the city of Chicago already, we had put sort of as our next 5 years, like what is the health department focusing on? What is the city of Chicago focusing on in health? We had already, prior to all this, called out the racial life expectancy gap, where in Chicago, Black Chicagoans live 8.8 years less long than white Chicagoans. And Latinx Chicagoans have seen, you know, a significant decrease. And the number one cause of that gap, half of that gap, chronic diseases. Diabetes, hypertension, you know, normally you can't get anybody to care about chronic diseases. Like it's never what anybody wants to fund. Nobody thinks it's like that interesting. But with COVID, suddenly these chronic diseases that are hugely, you know, huge inequities in who gets those and who dies from those in Chicago came to the forefront with COVID. And so we're really trying to sort of use our COVID response in terms of like, we put our community tracing, we're moving it all into sort of community-based groups only in the community areas that are high hardship and have these high rates of chronic disease, because the hope is that we will move, it's not just contact tracing, right? It's this preventive work. And we're hoping to move the COVID contact tracing core really into more of a healthy Chicago core, like community health worker type for this chronic disease prevention, which if we are ever gonna make progress, like as public health, we gotta take on. So we really said, let's pair the COVID response, funding and opportunities with this neighborhood focus, and then long-term, what's actually driving this, root causes, and then the diseases that sort of come from that are the chronic disease piece. So we'll see what happens, but it's been a major focus really throughout and from the beginning. And I am proud of what that looks like. I'm just worried about how, you know, pricey it is to do that well.
Okay, I'm going to go to some questions from our listeners. So there's a question that I'm going to broaden out a little bit about how various communities in your cities are trusting messages. And I think we've talked about that a little bit. So I'd like to broaden it out to how generally, you know, the whole population is or is not trusting messages that are coming from city and state officials around social distancing and other preventive measures like masking. So Gretchen, how has it been received, these, you know, things been received in Minneapolis?
Yeah, I think certainly there's lots of concern from businesses about the impact on businesses. But generally, when we kind of had our shutdown time early on, people were very compliant, and it worked quite well in Minnesota. I think it's hard for people though to take any kind of change in messaging and still hold on to that. So our governor has dialed back rather quickly, not as quickly as some and not as completely as some, but and so I think that has led to these social gatherings and the sense of, you know, we can't go back to restaurants and sit outside, or, you know, I mean, which is fine, but the complexity of the change in the message, I think, is really hard, combined with just pure exhaustion of being different and doing something different. And then I think we've got a lot of developmental stage needs. I know that I have an elderly mother, and I have spoken with others who have elderly relatives who are just beside themselves with the sense of isolation and how important being in community is for that age group. And then of course we also think about teenagers and how important, and young adults, and that's, you know, a reason that we're getting more spread in those populations, while they are not at risk of the highest you know, consequences, but they can spread it. So yeah, I think this long response is full of different stages of readiness to hear the message and different abilities to hear that message overall. I'm worried about things like, I know our professional football team wants to have a crowd of some sort. And we think that they can probably do it all right because they're very professional, but what message does it give to others and make them think about, oh, well, if that can happen, then all these other things can happen too.
Yeah. Allison, do you have anything to add on the
Yeah, I would just say a couple things. One is that we have very much tried, I think one thing that's been successful, relatively successful with businesses and churches and et cetera, even, you know, the football teams, is really to actually pin these, where there are restrictions in place, pin them to our local numbers and turn, if we're having this many diagnosed cases, this is how many undiagnosed cases we think there are based on what our mortality rate looks like. And with that many undiagnosed cases right now in Chicago, and we sort of explain the whole thing, this is the likelihood that if you get, 50 people together, someone in that group will have COVID and not know it. And that, like, explaining sort of that goes up and goes down. And so we've really, like you heard me sort of say, 200 cases a day, 400 cases a day, those don't have meaning, except that in Chicago, we've had them have meaning based on our population. And we've returned to them sort of over and over again. And so, like with the Bears, for example, they also, a beautiful, here's how we could do this. And we just said, from a messaging perspective, no, talk to us when we get back down under, this many cases. And we've helped sort of signal that these decisions we're making are based on data, and they're not arbitrary, and that we want to move ahead with things as much as everybody else does. And as soon as we can make progress this way instead of this way, we will be doing that. But I think that has been helpful in terms of this, some of the pushback, and it's so difficult. I know how difficult it is for everybody when there are restrictions in place. I think the other thing is that we leaned really hard into social media early. Like I personally did these Facebook Lives where we literally just take questions from the public. I don't prep for them. It's different than a traditional media thing. They're about 45 minutes. I've done at least 100 of them at this point. We were doing them 7 days a week at the beginning. At this point, we do them usually live a couple of times a week. I bring in a guest. This week we had the lead on the vaccine trial that's furthest along in Chicago, and then we take direct questions. And then on the days that we're not live, I film sort of answering questions in less than 2 minutes. We translate those into other languages and have really tried to embrace that and use that. And I think that has actually been reasonably effective in terms of people feeling like we are relatively accessible and willing to answer questions. And it's created some content that we can then sort of use across messaging. The mayor has also herself been very involved in messaging. There were a lot of memes where she really took on it, like, I'm coming after you if you don't do the right thing, but sort of funny. It took on, there was some humor in it, which I think is always helpful. And our sports teams have been helpful too. This is our current, we are all one home team. Like, these are our current sort of mask, but this followed the we are not playing during stay at home. Like, we've sort of done a lot of tie-in with the sports mascots. And I think that has also felt Chicago. And I think it's important that people feel like, at least here, that the messaging and the voices are local. I think particularly given the mix of messaging that is coming at the federal level, having some really consistent local messaging that we are focused on what we can handle, which is Chicago. And I will let, when the Chicago Department of Public Health says there's vaccine good to go, we're good to go, and trying to sort of build that up has been complicated in this political moment, but we've worked hard to do it, and have had just amazing messengers across the city willing to carry those messages.
Allison, you were the inspiration for this webinar series.
Oh, very good.
We were watching your Facebook Lives, and we were like, well, if Allison can do this with, members of the public, unscripted, we can certainly do a webinar series.
Yeah.
So there's, as always, there's a question about contact tracing. The question is, describe how you ramped up contact tracing activities and have maintained a high level of service in this activity. I think one of the messages we've heard again and again on these webinars is you can only keep that high level of activity if you're bringing cases down. So talk a little bit, Gretchen, let's start with you, about how you've handled that piece of the puzzle.
Yeah, early on, we were able to, the state took that on for a while, but then said, oh gosh, I think you all at the local level should be doing it too. And we're like, yeah, we're ready to help you out here. So we had our restaurant inspectors who weren't out and about because restaurants were closed, and they were really a good match with the skill set for contact tracing. Mm-hmm. We also have school-based clinics, and so the clinicians, the nurse practitioners, and the medical assistants and so on that work there were also a good match. And so we trained them up, and we had a good, robust team. Now restaurants are open. My restaurant inspectors need to be out in the field again. The schools would like to have the school-based clinics open, even though the schools are not open for students, but they want the students to be able to come for services. And so, yes, we have a dwindling supply now of our internal resources. We have an agreement with the AmeriCorps to find us some folks for 6 months, and so we're just finalizing that agreement. But yeah, it's and you can't redeploy your own staff all the time because there are other duties that need to be taken care of. So that's been kind of a rolling challenge, but so far we've been able to piece things together.
Yeah, and I would say, you know, here in Chicago, first of all, it's just interesting how contact tracing like grabbed everybody's attention. And we really do see some difference between case investigation, which is the initial conversation with the case, versus the contact tracing, which is somewhat more routine perhaps in terms of calling contacts. And these are presumably not people, well, hopefully they're not sick, or you just have to figure things out. And we have really worked to try to keep that initial case investigation where you're wanting to especially kind of have strong trust, et cetera. That has all been at the health department. And we've pulled people in, as Gretchen said, from all sorts of places. We have a lot of older staff at the health department. And so if there were people who were going to be working from home because they were in a high risk category and perhaps they couldn't do their work as easily, they were some prime candidates to move over. We also really tapped our HIV team. Like, if not for our HIV team, who of course do a lot of this contact tracing work all the time, I left our sort of communicable disease experts on the more complicated, like every time there's a workplace outbreak or, you know, anything that has to do with a healthcare setting, anything that's more complicated, like a place-based thing, that has really stayed with our communicable disease experts. And the more routine, like community-based contact tracing has really lived as a lead with HIV. But as you said, we pulled in like people who were normally like doing parking meter or booting cars, like people from other city departments, our Department of Cultural Affairs and Special Events, right? Like, what have they been doing? You know, even the law department pulled in some folks. We are losing those folks, as you said, like that they've been, you know, September 4th is actually when we're losing a number of these city people who have been filling in. And frankly, I need to pull, especially a lot of our Spanish speakers, back out of that work and into more of our kind of community outreach given our setting. So what we are doing kind of moving forward, way back, probably late March, early April, we wrote a letter like to the CDC and to our senators and everybody and said, if you're going to fund COVID like you fund HIV, here is how we would use that money. We want to use it to, you know, specifically to fund community-based organizations in these higher need socioeconomic neighborhoods. And we want them to do contact tracing. We want them to do outreach. We want there to be a resource coordination hub, again, building on some of the successful stuff we've done with HIV. It took a really long time for funding to come through, like just through the various channels and pieces, and some from the state and some here. But we did do a very large RFP and our big workforce partnership here that already does workforce development. Oh, and we specifically said we want to hire people who have barriers to employment. So people with histories of justice involvement, or they don't have to have had the training, especially just for the sort of more routine contact tracing, we'll train folks. And so there will be 30 community-based organizations, where we'll be announcing it in the next week or so, that they're just finishing up the selection process, who will in turn do the actual hiring for people from those communities. You got to be from those communities. And then we'll be training, we'll be pulling them in. And so we had to build a whole new tech platform to do that. I mean, this is like not a small venue or a small effort, but we set a pretty good rate there. And we did an earn as you learn. So anybody in this program through our community colleges is simultaneously getting some of the basics. I mean, obviously the training for contact tracing, but some of the community health worker training, phlebotomy training, like all of the sort of other health skills, because we're really, this is a 2-year job max. We're hoping to move these people, like I said, into our preventive community-based health worker, hook them up with our FQHCs. We sort of are hoping that some percentage of these people will end up even being sort of resource coordinators. We'll see what happens. But we're thinking of it. We said, not only do we want to solve this problem, but where there are opportunities to actually make real economic, there's more than $50 million, like economic investment in community areas of need, we want to do that. So we'll see. We are moving sort of, we'll keep doing it as long as we need to do it, but we're pulling in just a brand new type of worker and and partnership. And we think it's going to be, we think it's the right thing to do. We've never tried anything like this before, and we need to make sure we continue doing all our contact tracing. So it's going to be, this is another thing that will, the next really month or two is very much going to be about, but we're excited about it.
So Allison, all your colleagues across the country fell out of their chair when you said it's only $50 million.
Oh, okay. It's 56 million. We think that's a lot, but that's what it is. So,
Yeah.
just saying.
Okay.
Different scale.
Yeah. Okay. So I want to, well, we'll see if we get to 2 more questions, but I do want to get to one that I know that we have talked about a lot as the coalition, and we've talked about on every webinar. So for the sake of consistency, we've heard a lot about the mental health of frontline workers, and in the media that tends to be doctors and nurses working in hospitals. And not that we shouldn't be hearing those stories. There are also real implications for you all and your staff. So can you tell us a little bit about sort of what you've been seeing among these staff who've been working 24/7 since January, February, and the types of things that you're trying to do for them, because we all know this is a marathon, not a sprint. So Gretchen, let's start with you.
Yeah, well, I'd say it's exhaustion combined with commitment. I mean, there's still grit to keep working, even in that sense of exhaustion. And then in Minneapolis, we've had, the city itself has financial problems because of COVID, and then the civil unrest after George Floyd's killing. So we all have to take furloughs as well. So yeah, 4 to 6 days for everybody. And so that is not a real upper for everybody. Although I personally am appreciating the forced days off.
COVID doesn't take a furlough though. I don't know.
Well, I'm taking a budgetary leave of absence. Yes, I am. Just one day every pay period. So.
Got it.
And working remotely, I think, is also isolating. We did insert into our incident management team a position that has looked at the mental well-being of our staff, and so have sent out daily messages about relaxing and breathing and connecting people with some resources about how to take care of themselves. We also have a practice within the city of Minneapolis and within the health department to have safer space conversations, so to sponsor times when people can get together and just get things off their chest and have it be facilitated somewhat. Maybe they only want to come and listen. Maybe it doesn't feel all right to speak, but that has seemed to be really important and has become more and more fine-tuned so that there are subgroups that want to have their own safer space conversations, and then there's more general safer space conversations. So that is something that is a regular thing we sponsor, and then have also peaks of offering them when there's some particular stress in the community. I also just have regular all staff meetings now that are, virtual, but we used to have them quarterly. Now we have them every 3 weeks or so. And just to be able to impart information directly. And then there's a big question and answer section out of every meeting. And so to hear what people's concerns are, they can submit them ahead of time. They can do it anonymously. They can say it in person. I think that has taken some of the uncertainty out. And speaking of uncertainty, there's a lot of concern about being able to stay home and balance your family needs. And then, are we going to keep working remotely or not? And how do I know? And how can I plan? And so even as the city has been sort of like open-ended about answering that question, I have tried to make some commitments about how much time lag I would give people if we ever did demand that they come back. I can't imagine that we would in time in the next year. So lots of contributing factors to mental well-being, and so we're trying to address several of them anyway.
Yeah, I want to hear some more about the safer spaces thing at some point. But I think, along those lines, I actually am doing a weekly all staff update, same kind of thing, kind of like Facebook, where I talk for about 20 minutes, what's big across the department. And then 2/3 of the time is answering questions live from staff. I agree that, obviously that's virtual. Virtual is brand new to the health department. And so even that has just been difficult for people. Like our IT is just, people don't, there have been a lot of pieces that have just come together to make people's jobs hard right now. But I do think broadly here too, people have very much risen to the challenge. We've seen, administrative assistants running entire sort of programs of call lines. We've seen people really kind of owning this. And while I'm very appreciative of that, I also have really tried, like I've been telling everybody, like, I want you to use your vacation. You cannot use it all in November, December. I'm not going to let you, but put it in a more of a positive, like, I need you to actually be taking some of this time because I'm worried about people burning out. I actually took, a Thursday and a Friday, Saturday, Sunday off. That was like, really good. Trying to, set some example there. We also did put for the first time, kind of a weekly, there's a meditation, like someone comes in and does some meditation and talks about stress techniques. And it's a little bit of this maybe safer space idea, but we're trying to think how to do that a little bit better. And just trying to be as flexible as we can within the city restrictions that exist. I have just been trying to grant grace to people, and they got kids and they got this and they got that, and everybody has already worked their whole hours in the first 6 months of the year for the year, at least people who are in COVID type positions, and people have been very, very dedicated, and I've mostly been trying to get them to take time off, but it's been really hard. And I think also just that public health can sometimes end up being a little bit like it was our fault, sort of. And there's this sense of, it can be hard when you're getting just, people are unhappy with you. And so we did have one school class that I think was a little confused about what the health department does, but one of the high schools, or I don't know what they were, middle school, all the kids wrote, dear doctors and nurses, thank you, and whatever, and sent it. We put them up and it was great. Because we are not often thought of as health workers in the same way. And I try to kind of raise up good opportunities. We had a celebration yesterday. We moved the last of our homeless individuals who had been in shielded housing for COVID. We moved them into permanent supportive housing. And so we were closing that. So we actually took a minute and chipped in some money and bought people lunch, trying to remember to do some of that, even in the middle of everything, is really important.
So my 11-year-old told me early on that if I'd done my job better, we wouldn't have had a pandemic.
Exactly.
My husband thought he didn't know what was going to happen in the room, but we've moved on.
Yeah.
Thank you. So the question we usually end on is what gives you hope, but I know we are at time. So if you guys have to run, I'm happy to let you run. Folks, look at our website so that you can see the next series. I won't give my whole spiel, but if you have a 10-second, what gives you hope? Jump in, and then
the vaccine trials look good. It'll take a year, but they're coming.
Okay. Gretchen?
Yeah, and for me, I think it's that the relationships formed and the skills developed during this time are really going to pay dividends even after COVID is something that we are more familiar with and is integrated into our life better. So.
Awesome. Well, thank you both. Really appreciate your time. Thanks everybody who tuned in. Do visit our website because we're going to continue doing this webinar series as long as we have folks who can continue to give us their time. So thank you everybody. Have a great afternoon. Bye.
Thank you.